Good evening, everybody.
Good evening, sister.
Good evening, sister.
Good evening.
I hope you are all doing good.
By
Yes,
God's grace, we are fine.
Pray
We are
you.
doing good by His grace.
so we thank God. I'm also fine. So let's move on. You're welcome back. So today we are moving on to the malformations and pathological conditions of the uterus. I hope everybody can hear.
Yes, please.
So we are going to talk about the uterus. I'm sure we work with the uterus, but we hardly see it with our naked eye, unless we go for when there's a cesarean session. That is when we even see the word the uterus. But we palpate, we also take everything with the uterus. So the uterus is one of our easy rooms. We do not see without our naked eye, with the exception of what's going to the theater. Who can tell us something small about the uterus? Nobody. This is one of the main organs that we work with. Any brief description about the uterus? Our anatomy. Something small. Oh, who is helping? Nobody.
Sister.
Yes.
Good evening.
Can you talk to us? Amelia, talk to us.
Sister, okay, so the uterus is a hollow muscular pear-shaped organ in the female reproductive system.
Oh, okay. Thank you very much. Your hand is up.
Yes, please, sister, please, good evening. So please, the uterus is a pelvic organ, and then it lies in the true pelvis, which is anteverted and anteflex in position. And then the shape of the uterus is that of like a pear. It measures 7.5 long, 5 centimeters wide, and then 2.5 thickness. Thank you.
Oh, thank you too. Thank you all for your responses. If there's none, then let's continue. So like sister just said, it's just a hollow of muscular pair of shaped organ. And these are located in the female pelvis. So it only rises towards the account of an abdominal organ when there's what conception. That as a result of the product of conception growing or expanding, that is when it moves into the abdomen to become an abdominal organ. But the uterus is what? The pelvic organ. The normal position this sister has just shared with us. And I'm sure this is not new to everybody here. So let's move on. And this is just a picture of the uterus. And this comes with what? The fallopian tube, the ovaries, internal os, and others. So uterine malformation It is a type of genital malformation resulting from abnormal development of the Mullerian duct during what? Embryogenesis. You see, all parts of the body has a point that they develop what? From. So when it comes to the uterus, it develops from what? The Mullerian duct, or you can even call it the personific duct. There's just some small dots during embryogenesis that develops to form what? The uterus. So when there's any deviation or there's any issue with this duct, then it definitely is going to result into what? One of the various malformations that we are going to talk about. And we have general symptoms of what uterine malformation. So it mostly affects clients with recurrent or pregnancy with loss. It is the uterus. That's how is the product of conception. So that the baby grows, everything, placenta, whatever. It's the uterus that keeps the baby for the 9 months. So if there's something wrong with the uterus, there's no way it can hold or the product of what? Conception. So most people would do try any of the types. There's a history of what? Pregnancy loss. And we have what? Menorrhagia, infertility, and sometimes what? Things. These are general symptoms of the uterine malformation. So let's move on to the types. There are types, as we did previously with the vulva, vagina, cervix, and others. So there are also types of what? The uterine malformation. We have the Mullerian agenesis. Also known as what the Mullerian
Can't hear you.
And with the Mullerian agenesis, the symptom is what? Absent what? Uterus.
Hello, sister.
Sister, please, we can't hear you. Your voice is very far. We can't hear anything. The voice is very far. And please, can you kindly go over?
Hello, please, is it okay now? Can anybody hear me?
Yes, sister.
Yes, sister, it's clear now.
It's better. All right. So all that I was saying was the uterine malformation. Like I was talking about the body organs, during embryogenesis. We have parts that develops to form what? The uterus. But when we have parts that develops to form what? The various what? Organs. Then when we come to the uterus, there is this duct, that's the Mullerian duct, or the personific duct. These develop to form what? The uterus. And I said we have general symptoms affecting what? Uterine, or people with what? Uterine malformations. Like I said, it is the uterus that holds what? The product of conception. So if there's any issue with the uterus, there will be disaster. And people affected with any of the malformation that we are going to talk about, most of them present with pregnancy loss, menorrhagia, amenorrhea, infertility, and what? Pain. So these are general signs of what? The uterine malformations. Please, I hope you are all okay now. Can we move on?
Yes,
Those who were
sister.
saying, are you okay now?
Yes, sister, you can hear now.
All right. Let's move on. So the types, like we did for the previous weeks, we talked about vagina agenesis. The same thing can happen to the uterus. We also have Mullerian agenesis, which means absent uterus. As a female is born without a uterus. So we have other names for that. We have the Mullerian aplasia, Caster-Hauser syndromes. Yeah, that's also another name for that. And the incidence is 1 per 4,000 to 5,000 what female. So meaning in 4,000 to 5,000, there's likelihood that there will be one female baby without what? Into female money without what?
Amy,
People,
sorry. I mean, Mo, thank you. Why?
so there are people or females born without what? Uterus. So the sentence that the condition is hormonal or typical. So we have affected girls, they usually enter puberty with what? Development of what? Secondary what? Characteristics. So most of them enter what? Early stage. That is, they mature what? Early. Then their vagina too is usually very, very what? Short. But they have no uterus. So assuming you have a short vagina and you meet a man with 6 inches, definitely there's going to be what? Pain. So most of the time, when they complain of pain, all these things, you should look out for what? Some of these things. They are all what? A possibility. So with them, intercourse can become very difficult and what? Painful because the vagina is what? Short. So even though we say what the vagina is what? A potential canal or whatever, we have actually the vagina can accommodate any size of what the penis. In this any case, we have people with what? Short what? Vagina. The diagnosis, we should do what? Radiological, then endoscopy. Then you have to do vaginal examination. Because when you go in and it's short, at least your hands will meet some kind of what? A resistance. So after you do your vagina and you're meeting a resistance, it means what? You have to go further. Whether you go for the radiological or what the endoscopy what? Examination before you can what? Treat what? This lady or woman. Then with a pregnancy outcome, it's only the ovaries, they do not what develop for more than layering with that. So it is possible that as a woman without what a uterus, but the ovaries may be what present. And this means they will have what a normal secondary sexual characteristics. It is only that they will be what infected or they can't carry what their own what babies because there's no uterus. But the ovaries will be there to produce all the hormones and others. So when you see them, they are normal what females. So when it comes in case of what childbearing, then now there's surrogacy and what others, or even what adoption. So they are okay, just that their uterus is what absent. And now there's even what a uterine what transplant. Yeah, it can be done in the advanced what countries. I don't think Ghana here. I don't know if any of your facilities uterine transplant is being done. Is there anybody here who can share with us if your facility at least there is one? So it's Ghana, I don't know of any hospital that can perform this kind of surgery. But I stand to be corrected. Is there anybody here who is working in a facility that they can what? Can you do this kind of what? Offer this kind of service to women? Anybody here to share with us? Then since everybody's quiet, it means there's no hospital in Ghana that can offer this kind of treatment to affected ladies or women. But in the advanced country, it can be done. So the second one is unicornuate what? And this is smaller than a typical uterus. Just like what they have size of what? A normal uterus. And with this, it has what? A penis shape or a banana shape. As during X-ray or what? Scan. That is how it looks like. Then the incidence is 1 in what? 1,000 women. So the first one was about 5 to 5,000 women who come out with what? Menorrhagia or agenesis. Then with the unicornuate, it happens in 1 in what? Every 1,000 what? Women. They do have, but the uterus is present, but it's not normal. It is very small, like that of what? A divided uterus. So they count with what? Half. I think I have a picture. So with a half uterus or what? The unicornuate, even though pregnancy can occur, but they may have what? A difficult what? Time. So the unicornuate is known, it is known to have the poorest what? Fetal what? Survivor. Because it is just half. And it is very, very what? Small. So it compromises the flow to the uterus. So where would the placenta even be? We all know the size of what? We all seen banana before. The shape of a banana or what? A penis. So assuming the uterus look like what? Like a penis. How can a baby survive in this what, shape? So the unicornuate is what? Known to have the poorest what? Fetal what? Survival. Even though they have a uterus, but it is hardly to carry a baby to term. So you mostly need what? Spontaneous what? Abortion. So this is how it looks like. That is the first one. It is just half. You can see just half. The other half what? The first one on top is the normal what? Uterus. And the first one below is what? The unicornuate what? Uterus. Then the third one, we have also a double what? Uterus. So uterus was either fails or what? A double what? Uterus. So what there's the uterus is formed during what? Embryogenesis by the fusion of what? That's the paramesonephric what? That or the two what? Mullerian what? That when they are fused what? Together. But with the uterus, we have what? Two. We have the bicolex and unicolex. With the unicolex, they have what? One vagina. But with the what? Bicolex, they have, it comes with what? Two what? Or double what? Vagina. So we can have a woman with what? Double uterus, double vagina. Or double uterus with what? One what? Vagina. Because the way that was decided to fuse. So they do form what? A single uterine what? But so under the double uterus, it can come out as either bicolex or unicolex. And they do exist. Yes, they do exist. So pregnancy may take, with a double uterus, may take a normal course. So they can, all the two uterus can be pregnant at the same time. So we have multiple pregnancy are common in separate uterus. I'm sure in the olden days, but I think now we won't tolerate that. And sometimes our grandmothers will tell us that, hey, these people, they are twins, so but one was born before, sometimes 4 days, or even a week, or even weeks apart. So you come across twins, we have one is Ya and the other is Ama. So you try to find and say, how come? Oh, they were born with some days or weeks apart. But in our era, we wouldn't even take chances. If one comes out and you refuse to come out, we will wheel you toward the theater. By force, we will remove you, whether you like it or not. I'm sure, is there anybody who has come across that before? Or you've heard some before? That we have twins who were born with days or weeks apart. Is there anybody here who can share his or her experience with us? Who is sharing with us?
Sister,
Yes.
sister, good evening. Sister, please, how are you?
I'm good.
I'm fine, sister. Sister, please, I had a SHS mate.
Okay.
She was a twin, but they were 11 days apart. But we didn't understand when we were in SHS, so it's when I got to nursing that I understood.
All right. Thank you very much, Belinda, for sharing with us.
You are welcome, sister.
Is there any other? So like Belinda has shared with us, she had a classmate who were twins and they were 11 days apart. So this is a typical example of what? A double uterus. It means they were all conceived in a different way. Yes, Clifford, your hand is up. If your hand is up, talk to us.
Yeah, sister, so in my faculty, we had this client. She came for EOE. When she went for the scan, I think she was, is it 10 weeks or 12 weeks? And she said she opted for MVA. So we did the EOU for her. And we told her to come back in 2 weeks' time for scan. When she came, she was 13 weeks pregnant. So we're all like, but we did the thing. We showed the product to her. She saw it herself. But 2 weeks away she came, she was 13 weeks pregnant, and the lady had delivered. I did the delivery. So we're suspecting that she had that double uterus.
That's a typical example. Hey, so with the 13 weeks, what did you do to it?
We didn't do anything. She just continued with the pregnancy. She just continued and she came to deliver. I didn't do the delivery.
Okay. So this is a typical incident of what? A double what? So they do what? So thank you all for sharing with us. So that, like they are all saying, an occasional delivery may be impeded by what? The septum in what? The vagina. So in some cases, menstruation may occur throughout the course of what? Pregnancy from the non-pregnant uterus. That is why we have other people too. They might be pregnant, but yes, though they'll be menstruating. Sometimes you wonder, like, if I'm pregnant, I still what menstruate. And most of the time you overlook it. Oh, it will stop. We should probe what more. And diagnosis, the X-rays, radiography, pelvic examination, ultrasound, MIR, and what others. These will help us to diagnose. So assuming somebody is 20 weeks and still menstruating, we shouldn't just take it lightly. We should investigate to know whether and confirm whether there's a double uterus or if there's something wrong. So the treatment, if no symptoms are present and there are no complications with fertility. If it's not interfering with fertility and pregnancy, it means there's no need to treat them. But pregnant women with this condition need special care. Assuming a pregnant woman still menstruating at the same time. High risk. It means we should put care. Take very, very good care. Assuming you are pregnant, your body is now making the placenta is taking nutrients and nutrition from you to the baby, and you are still also losing blood at the same time. It means the whole body is under stress. There is chaos in the system. So we have complications. It might also lead to miscarriages due to the smaller size of each uterus. Sometimes there's premature labor. They are not able to carry a pregnancy to term because of the size. Then we have intrauterine growth retardation, infertility, and we have malformation because of the size. So most typical example is the breech presentation, which is very, very common with this kind of malformations. Then the next one, we have the biconate uterus. That is a uterus with 2 horns.
Sister, good evening. Please, can you explain the infertility for us? How the double uterus can cause infertility? Thank you.
All right. Like we're also saying that there are cases of miscarriages because of the smaller size. So assuming they are able to carry pregnancy all the time, 20 weeks it comes out. If you not carry a baby to full term and you are all experiencing miscarriages, are you fertile? My sister, help us.
No, please.
Always say a woman is fertile when at least can be able to carry
okay, thank you.
Is are you okay? All right. So let's move on.
Yes, please.
The biconate uterus. Welcome. You have uterus with 2 horns. So this is formed when the Mullerian that incompletely fills at the level of the uterine funnel. So whether the lower uterus and cervix are fused, resulting in 2 separate but communicating endometrial cavity. Whereas there's a single chamber cervix and vagina. So with this, the incidence is not less than 1 in 200 That means the biconate uterus is common compared to what we talked about.
That's right.
So there are 2 forms of these, which are uterine complete the uterine section that extends either to internal os. I think I have the picture of it here. So this is a picture of the biconate uterus. The first one is the fascia. and the second one is what the complete. You all can see that at the level of the fundus, they are fused together. We have either partial or what complete. And these are common. It is just that here, I think our investigations are poor, let me say it that way. But 1 in 200 women means what is very common compared to what the others. But here our problem is, so far as you are able to achieve what pregnancy, at least we don't put our head about these things. Then with the pregnancy outcome, we have obstructed labor. That is due to the obstruction by the non-gravid hormone. Then there's also a repeated abortion and breech presentation. So most people will be having malformation. It means what? There's something wrong. So anytime the presentation is even breached, it means we should probe further to find out the kind of uterus. But do we do it? We don't. So what we do is we advise the woman about position, raising of legs and others. Some are fortunate the babies do and others don't. Others remain breach the bed. So it means in cases with breach or bed, we should find out what kind of uterus the woman was carrying. So this is telling us that most of the breech presentation women that comes with malformation do have problems with their uterus. There are complications, premature labor, late abortion, and even deformity. All these will result out of a bicornuate uterus. Then we have the separated uterus, that is the uterine septum or the uterine partition. So this is when the two mullerian that have fused, but the partition between them is still present, splitting the uterus into two parts by a muscular or a fibrous wall called the septum. And this is 1 in 45 women. So here you can see the septum here, where the fallopian tubes are. So it means most of women walking around do not have a normal uterus. So malpresentation may be more frequent. Like I said earlier, it means anytime there's a malpresentation, it means there's something wrong with the uterus. Retained placenta and pH. When the placenta is implanted over the uterine septum, affected women find it more difficult to conceive. So this is also now even opening our eyes more, because ideally, after the baby is out, less than 3 to 5 minutes, the placenta should detach and come out. There is in some cases, sometimes you have to do manual removal, followed by EOE. So anytime we're having complications, we should also think about the uterus. There's something so that at least we should write it down even after delivery. We need to do investigation to know how best we can handle their issue when it comes to their next pregnancy. And I think this will go a long way to help. But we have people noted to always have BPH. Sometimes you just open the pink card or the ANC card, then you see boldly written with red pen, PPH. It means all her previous pregnancies, there was PPH. Then do we find out the cause? What is actually causing this? The possibility of a separated uterus is very high. Then the incidence is 1 in 45 No. So most of the issue for more is to find out what is actually wrong with this one. So the treatment, that is, the septum can be shaped of doing hysteroscopy or the menstrual plastic to form a single uterine cavity. So instead of always writing PPH, we should find out. So in case we find that there was a septated uterus, at least treatment can be given. So on their next subsequent pregnancy, they don't have to what, at least lose blood. And this can go a long way to what, save life. And we all know when there's PPH, even you, the midwife, you sweat. It is not easy when it happens. We go through hell. Just to arrest what, and we are also not comfortable about it. So when it happens, why don't we go further? Because at least subsequent pregnancies, she wouldn't have to go through that. Then we have the aqueous uterus. So this is form of uterine anomaly where the uterine cavity displays a concave contour towards what the fundus. And the incidence rate is 7% of all uterine anomalies. So when it comes to the aqueous uterus, with a pregnancy outcome, this is how the aqueous uterus looks like. So with the fundus, you can see that it transformed with a concave contour. Those who did geography, these are your terms. And towards the fundus. But if instead of it going up, it has rather form a concave contour towards the fundus. We are saying that the aqueous holds 7% of uterine pregnancy. So when it comes to this with the aqueous uterus, most of the time the fundal notching are because at late pregnancy. So this is the result of most transverse line. So you palpate and the line is transverse. So anytime we come across a transverse line, we should be thinking that there's a possibility of this woman having an aqueous uterus. So there is depression at the fundus. So anytime there's this is one of the key suspects. Then we have the dense uterus. That is disylvectoid uterus. It is just a uterus that resembles the letter T. So this is just a result of fetal exposure to testosterone fat when they are exposed to it. It means the uterus or the fetus is going to have a uterus that resembles a T. So this is normal, and this is how it will look like. So this weather affects the fetus. So let's move on to the pathological conditions, as we did for the vulva, vagina, and others. We also have endometriosis. So this is just an inflammation or irritation of the endometrium. Then we have causes. So this is inflammation of the inner lining of the uterus. So with the endometriosis, we have causes as the infection. We've already discussed the cardinal signs of infection, and also going through a long labor. And everybody going through a long labor means that you'll be exposed to frequent vaginal examination. If vaginal examination is not done under aseptic techniques, we can introduce bacteria, and this will affect the lining of the uterus. We have multiple internal examination, yes. Then when there's premature rupture of membrane. But there are some facilities, whether it's a protocol or whatever. What's in this name? But I don't even want, there's no need to even mention the name of the facility. And as soon as you go into labor, They don't wait for the membranes to rupture spontaneously. They do a rupture of what? Artificial rupture of what? Membranes. Please, are we still doing that? And when they come at least 4 cm, from 4 cm, when you get enter into active labor, it means they will have to what? Artificially what? Rupture your membranes. Please, what is happening at your facility? Is it a protocol?
No, please.
Please, can you share your experiences with us? Is it a protocol that when a woman, at least from 4 cm active labor start, you have to rupture membranes artificially? Midwives, share with us. Or we do wait? What is happening at our various wards? Because when I had an issue with them, like, at least 4 cm, 5 cm, why don't we give the woman some time? You're like, oh, yeah, that is what we do. You have to rupture the membrane. Sounds like, in fact, I was kind of disturbed. But I don't know what is happening at your facility. Are we all doing the same thing? Can somebody share with us?
Sister, please no, we don't rupture the memory artificially at my end. Sometimes
Okay.
we wait till maybe the client is at 8 cm, 9 cm. That you've seen that now baby head is well descend. Like maybe at the descent is like let's say 1/5, then you can rupture, but not when the client is at active phase 4 cm, then you rupture the memory. Abi we were taught when memory is being ruptured early, the woman might have to be covered with antibiotics. So if we rupture the memory so early and the woman is not able to deliver early, you cause harm to the woman and the baby as well. So we don't. Thank you.
Oh, you're welcome. Thank you very much. In fact, I had an issue with it, like, how? I mean, why would you do that? And that is what it would mean. It was a protocol at that facility. Well, it's not the best. But means you can expose this woman to what? Infections and the baby too. And let's move on. When a small piece of the placenta is left in the uterus after what? Childbirth, you have infections like gonorrhea and add all the STIs who will result into what? Endometritis. Then mixture of what? Normal vagina what? Bacteria. So we have risk factors. So when there's premature rupture of what? Membranes. Repeated vaginal examination. You know, microbes are everywhere. Even though we are doing our possible best, but there's no way we can what? You can have 100 what? %. So the best that we can do is what? Avoid what repeated what? Examination. What is DNC, retention of placenta, fragments, and added. And sometimes cesarean what? Section. And also placement of intrauterine what? Divided the IUD. So anytime we are entering into a woman's what? You even touch the vulva vagina, it means what we should be going in what a sterile what gloves. I have seen people at different facilities using a disposable glove to do vaginal what examination. Sometimes I wonder hospital economy at the expense of somebody's health. This is not the best. Please. All these put the woman what at higher risk of what infections. So you have clinical manifestation. That's abdominal. There's abnormal vaginal bleeding with what dysmenorrhea. Abnormal vaginal discharge, which is very, very what offensive. There's low abdominal pain, fever, general discomfort. So all the cardinal signs are what's present when it comes to what the clinical what manifestation. The diagnosis is mostly through physical what exams, pelvic, then culture from what the cervix. So at least we cannot isolate what the causative what organism. Then endometrial biopsy and what laparoscopy. All these can help to what diagnose what endometritis early for what proper what management. So with even a physical examination, that's when you touch the lower abdomen, it may be very, very what tender. So we should take note. Anytime you do that, you touch and at least you know something is what not right, and we should act as fast as possible. Then we want to treatment. How do we treat what endometritis? That the sexual partners may also need to be treated. At least you do your test and you find out that in case they are suffering from chlamydia, gonorrhea, and other what STIs. You don't just treat the woman and be like, oh, she's okay. All her sexual partners should be invited to be treated as well, so that we prevent what a recurring what infection. But for my case, that's for vaginal delivery. That is why after delivery we give us the amoxicillin, amoxicillin, and what the fragiles and what others. All these help to combat what infection. Then when there's serious or complex cases, especially after what years, then means we need to give the IV what fluid. And we should know that surgical management is not usually in what acute what endometritis, DNC. But now, thank God, we are making good use of what the NV. Sometimes the pirouettes and others rusted with instruments. But thank God now we are using the NV. Then the drug management, clindamycin, gentamicin, and others. But I don't know of your protocols. Sometimes some facilities do have what protocols for specific what management. Sometimes it also depends on your facility or hospital what protocol. But clindamycin and gentamicin are very, very what good when it comes to what endometritis or even infections. Metronidazole, which is also another what popular what choice. So prevention, that's complete treatment prescribed for what STIs. We need to educate them. See, there are some of our patients, as soon as they start taking their even anti-malaria drugs, they take for the first day, second day, they be like, oh, I'm fine. They throw the drugs somewhere. But there's a need to educate them on what the completion of what the dosage. Then we have antibiotic therapy doing with cesarean what delivery, which I'm sure every facility is doing this. Or sometimes even before surgery was start. Then sterile equipment and techniques should be used during what delivery or what surgery, which I'm sure now more than Ghana. In fact, everybody is using a sterile equipment and what technique. Those are the chief compound. I'm sure you have the autoclave and what others. Then also practicing what safe what sex. When we talk about practicing safe sex, we have individual differences. There are some who practice anal sex. So I mean, when you are practicing anal sex, if you are going for the anal sex, stick to that. Don't go through the anal for some 5 minutes. The men, until you are here, 5 minutes, then you bring it out, then you enter the vagina. It means what? You are exposing this. In fact, you are killing your woman slowly. So please, if by mistake it slipped into what the anal region, most women will scream wrong hole. Please make sure you pause and go and wash the penis before you come back and continue. Please. That is what we mean by practicing with safe sex. Make sure our fingers are well trimmed to avoid what? Introducing it into the vagina. There's a complication, infertility, septicemia. So assume you move from the inner region then straight to the vagina. We all know where the anus there is what? Feces and others. A whole lot of harmful bacteria. It means you have directly introduced them into what? The vagina. And this will ascend into the cervix, the uterus, fallopian tube, ovaries, and possibly what? Into the blood. And this is life what? Threatening. So we should be careful. Then peritonitis, septic shock, and we have what? The tubal ovarian what? Abscess, which we will talk about when we get to the ovaries well.
Sister.
Yes, please.
Sister, please, you've said that if the man is having the rectum, the man to continue with the rectum alone, but not to do here and come to the vagina. So I want to ask that, like when you come across a woman, like a woman who confide in you that the man does that, do you have to educate both of them that the rectum is not good and with it complications, or you tell them that if they are doing here, they should do here, they shouldn't do here and there? Which one is the best, please?
Okay. Right. Charity, thank you for your question. Please, who can answer Charity for me?
Please, I can answer her.
Okay. Answer her.
Okay, good evening. Please, Sister Charity, with this kind of couple, you educate them on the risk involved in anal sex for the woman, for both the man and the woman. Yes. And you also educate them in case they decide that regardless of the risk, they'll still indulge in it. You also educate them on how to do it properly so that the woman does not end up with the infection. That is why she's saying that those who are doing it should not, you don't start with anal and then you continue with vaginally. Yeah. So if you are doing the anal, do the anal only so that you don't introduce infections into the vagina. That's what sister is trying to say. But she's not saying that anal sex is good or something. It also has its own way. Thank you.
Charity, are you okay? Because for a couple to engage in anal sex, most of the time they all agree. It's an agreement. So far as the woman has accepted, your possible best is what? Educate them, like Peter said, on the dangers of anal sex. But sometimes you can't force them. It's a choice. Life is full of what? Choices. If they have said that this is what we want, it is best you would educate them on what, so that they can practice what? Safe sex. If they today this they decide that, oh, today we are going for anal, let them finish. They shouldn't what? Mix the two. Assuming you give anal 2 minutes, then spray it to the vagina. No. You're doing that, we are exposing the woman to harmful what? Bacteria. And this will endanger her life. So I hope, Charity, you are okay.
Yes, please, I'm okay. But my concern is it's
right,
better you educate them on the complications that may arise from the anal before you encourage Yeah, thank you. I'm okay.
All right, okay. So let's move on to next one. What is endometriosis?
Sister, please, my hand is up.
Okay. Yeah, talk to
Yeah,
us, Mary.
as the other lady is saying, I once had a case like that where the
But
lady
then we
told
can't
me,
hear you.
I'm saying that I once had a case like that where the lady told me that the husband said because she's pregnant, her vagina is so hot, so he cannot go there again. He wants to go through the back. And the lady wasn't
Mm-hmm.
comfortable with that. So she told me about it, but the husband wouldn't
So
come.
with your case, it means the woman has not consented to that, right?
Yeah, and the husband is not willing to come.
Oh, that's good.
So we couldn't help the lady. He said that the husband threatened that if he wouldn't agree, he would divorce her. And a whole lot of issues. So when it comes to that, what can we do?
Oh, like you're saying, Mary, it means the woman has not consented to that. Even sometimes I ask those who practice that. Sometimes when you experience constipation and you are forcing this stool to come out, what do you go through? How do you feel? But you have to strain. You come out like a pregnant fish. And considering somebody who is pregnant, constipation is a normal disorder. And now you also want to use the back. Some men are wicked. In fact, you need to advise the woman to choose herself first. There are a lot of instances that the woman is scared to divorce and they agree. And when the anal sphincter gets wrong, it means you'll be leaking feces. And you think this same man will stay with you when you're leaking feces? Now that you're not leaking feces, it's cheating. So why do you allow yourself sake of marriage for somebody to destroy you? In fact, what I can say is the man doesn't even love her in the first place.
I think so.
You see, sister, sometimes the men sometimes it is out of ignorance. I can say some of them watching
No,
this kind of porn and things.
you
Then
know,
they also think some of the men, I'm saying some of the men, is out
right.
of ignorance. So with this, I think you can invite the man alone, even without you tell the woman you invite the man, then you take the man's number, then you call the man to cancel to cancel him. Some of them is out of ignorance, watching this kind of porns and things. Then they think, oh, I can also do this, I can also do that. So if you counsel and educate the person on the outcome of that, some of them can comply with it. Other than telling them that if you will do here, you do here. If the thank you.
All right, Charity, thank you very much. That could threaten her that if you don't allow, I'll divorce you. I mean, that is too bad. Pregnancy itself is very stressful. I wish one day we could switch for the men to get pregnant and have a feel of it. It's not easy. Pregnancy with all its stress, constipation. Then somebody experiences constipation, you want to insert this hard rod in there. Oh, like I said, but we need to empower our women to choose themselves first. We have had several encounters that the women agree and now they are having issues. The men have left them because now they stink. But if you had chose yourself and left, there's no way by now you'll be experiencing the complication and they have left you on top too. That is the most sad aspect. They will leave you. Kind of complications sets in. So we need to empower our women, at least to stand for their rights. And we have also women who, because of marriage, in the name of marriage, during the relationship period, the man will be like, oh, let me try. Don't start what you can't finish. If you were giving it to him before marriage, it means you should be ready for that. So we should empower these our teenage girls not to start something that they can't finish. I think that will go a long way to help. So with the endometriosis is a gynecological condition in which cells from the lining of the endometrium appears and flourish outside the uterine cavity. And the incidence is common among women in their 30s and 40s. So with endometrial tissues, so they grow in what? The vagina. They can also grow in the cervix and even ovaries. And even sometimes it might even spread to what? Other parts of what? The body. But the actual cause of this is what? It's unknown. Most of these things we really don't know what the actual cause. We just only attribute to what somewhat factors. So we have the menstrual flow disorder. You know, there are some people who do experience what the retrograde was menstruation. You know, menstrual blood also contains what endometrial cells. So assuming there's a flow back through the fallopian tubes, these endometrial cells can do what get themselves attached to what the fallopian walls. So wherever they find themselves, they can what attach and what flourish. And that is a disorder. So one of the contributing factors of endometriosis is those who experience what the retrograde menstruation. Then we have genetics. They believe that it runs in what family. We have other conditions, sickle cells and others. Sometimes even when your late grandparents, sometimes that's why we even ask, we take menstrual history. Medical history. Is there any epilepsy, HPT, diabetes, and others? Some of these conditions are genetic, and it's believed that they run in what? The family. So it's likely if any member of the family has experienced it, the likelihood of you also experience it is what? High. Then we have an environmental factors. Especially with what the pesticide. And so I think most of them even have warnings on them. This pesticide contains what harmful chemicals. And these can, when we are exposed to it, can have a long way to what affect us. Then I think we have surgical scars. We have surgical scars, and the endometrial cell can attach to what? An incision made from a procedure. As I'm doing what? Session. And this means the moment when they are able to attach, they will also grow. But they find themselves in the wrong place, but they are receiving all the nourishment. They will flourish. Then we have the immune system. That is, problems with the immune system may fail to find and destroy what endometrial tissue, which goes outside of what the uterus. When you have poor immune system, It means they can't fight unwanted work. Even though the endometrium is part of what the body. But when they are found in the wrong place, the immune system is supposed to be able to fight that so that they do not grow. But if the immune system is down or very low, the strength is what? Very low, it's compromised, it means they can't do that job. And you also have what? Hormones. Now, I think there's another slide. So let's move on to the risk factors. It is believed that the age of what, like anyone can develop that, but age 20 to what, 40 years are at what higher what rates. Then we have the knowledge what parity, and we talked about the genetics and also what medical what history. The medical history when there was different what abnormalities or even sometimes an infection could also lead to what endo what detritus. Please, a minute, please. We are saying with the age, the 40 to the 30 40 is very, very what common. But what is it starts from what menopause. It does that it progresses with as time goes on, it doesn't happen all of a sudden. So when it starts at menopause, there's what a progressive what over what years. And we all can tell from 30 to 40 at least. So that's most of what the reproductive what life. At this stage, women tend to deliver more and all these
Sister Chris, we can't hear you.
Results into what endo what is right. Or is this level that the symptoms would appear more of the time? Because at this level, the hormones are what at its peak. Please, is it okay now? Hello? Please, can you all hear me now?
Yes, sister.
Yes, sister.
Or it's still bad?
Yes, sister.
Please, is it okay now?
Yes, sister, please, it's okay.
You can hear me. Okay. I was saying, I was just explaining the 30 to the 40, why it's very, very what's common and why it's a risk factor for the endometriosis. I was saying at this level, our hormones levels are what at its peak, and we have tissue growth what intensify. You know whether it starts from menarche, but because at that age, it takes some time for it to progress. So at this age, because the hormonal levels are at its peak, that is when most of the symptoms are shown. So that was just what I was saying about it. Then we have the signs and what symptoms. It leads to what dysmenorrhea, dyspareunia, chronic pain in the lower back and pain. There's also excessive bleeding or spotting between what menstrual flow. Because these cells are found at a place where they are not supposed to be. So the little touch or a little trauma will lead to bleeding. It could also result in infertility, constipation, dysuria, nausea, and vomiting. Ali, your hand is up.
Yes, sister. Please, can you please explain the nulliparity as a risk factor for endometriosis? Thank you.
Ali, come again.
Please, I said I don't understand the nulliparity as a risk factor. So if you can please explain it.
As a risk for endometriosis.
Yes, please.
You are saying you have a problem with knowledge as
Parity.
a risk factor of endometritis, right?
Yes, yes, please.
Oh, okay. All right. You know, the endometritis just was something who has not giving birth before. You know, when they are pregnancy, menstruation was ceases. Please, are you okay? And we did talk about retrograde what those who suffer at the menstrual problems. We did talk about one of the causes that the retrograde was menstruation. And when we talk about not the palate, somebody who has not given birth before. So assuming somebody experienced this retrograde was menstruation. Time that going to menstruation, there's what menstrual blood is flow back, and this will lead what put them at a very high risk for what endometritis. Because when there is pregnancy, there are no more what menstruating, and this will decrease at least their chances of what the endometritis. So as a knowledge, they are exposed what to long what menstrual what refluxes and what estrogen. Ali, are you okay?
Yes, sister. Thank you.
Are you okay? All right.
Yes, sister.
You're welcome.
Thank you.
All right, you're welcome. So diagnosis, that is pelvic examination, there's laparoscopy, ultrasound, and MRI, all these things. Through this, what ways we can what investigate more, and they would go more like either it is pure endometritis and what, so that proper management can what. MRI will give us a visible what clear picture of the so that at least we can what manage. So with the endometritis, there is no what cure. So it can't work. But at least even cure, there are some place. We have what pain what management. And pain management, just talk about what the NC, the bruising, and the others, and what others. What others. Also have the hormone as the best. So at least the birth control pills also be at least maybe what recommended with the IUDs and what others. Therefore, Provera and what others. All the birth control at least types. The hormonal one at least can, and these will help what at least manage, but it can be for sure. Then we have surgery. This surgery is just done to remove what? It's a temporal what treatment. They remove the area of what the endometritis. But at least what we can do when it comes to the surgery, hysterectomy can be done. But sometimes when you do hysterectomy, and most of them they do it and they remove both the ovaries. When you remove both the ovaries, that can work with disaster. So with the surgery, they'll just remove just the part that has been what affected. So we have fertility also what treatment, but sometimes it's recommended. But maybe you get pregnant. Sometimes do what the IVF.
Hello, sister.
Why the emperor was a risk factor. But at least
Sister, sorry to interrupt you. I can't hear you. I didn't hear you on the surgery part. Please.
Oh, okay. Let me come again. I was saying with the surgery, like I said, with the endometritis, we have no permanent cure. It has no cure for that. And I said it can be managed under what we have pain management and the hormones that we talk about. But with the surgery, they just remove the area that has been covered by what the endometritis. And I was saying sometimes like hysterectomy can be done. But most of the time, it doesn't help a lot. Yeah. So sometimes they just remove the area that's what the endometrium are what affected. Please, are you okay?
Yes, sister. I'm okay. Thank you.
Then we have complication. It will lead to what infertility. Assuming your whole the whole uterus is being covered by this, and it means what everything has to be taken out. Without his rectum. And no uterus, no baby. Then it could also lead to what ovarian what cancer. Because where the cells are growing, they are not supposed to be there. So it becomes an abnormal where they find themselves a displacement. So even though they belong to the uterus, but where they are found at the moment, they become an abnormal cells. And this leads to abnormal growth. So it can also lead on even affect what the ovaries and even nearby what organ. Or sometimes they can even affect even the lungs. So it's a serious condition. So let's move on to the fibroids, which I mean it is not new here.
Sister, please. Hello.
Yes, coming.
Yeah, sister, about the treatment for the endometriosis. This doctor, he will always give the client Promolate N. I don't know whether that one too is the hormonal treatment or whatever.
You said the doctor has been giving what? Promolate what? N. Hello, Mary?
Yes, please. You will be giving them Promolate N, what we call the N tablet.
Yeah, it's used to at least. It's also a birth control. Please, are you okay? It's also a birth control what pill.
Okay, thank you.
Please, let's move on to the fibroids, which I mean is not new. The uterine fibroids are just they are non-cancerous tumors that grow from muscle layer of the uterus, and it varies in size. You have some as a bean, and you have even as large as what a mirror. As if this guy is what we all know what a mirror sizes. It comes in what sizes. Some because of the fiber, when you see that, you might even think they are even pregnant. There is no pregnancy. We have types. We have types. We have the intramural, the subserosa, and the submucosal fibroid. Just as the name. So the intramural is the most commonest type, which all the other types. The intramural is the most common type. And with this, it's just as the name, intramural, is embedded in the muscular wall of the uterus. That is just the name can give us a hint of where it can be found. So these they just embed themselves in the muscles of the uterine wall. And the intramural are the commonest type of all the fibroids. Then we have the subserosal fibroids. These extend beyond the walls of the uterus, and they grow within the surrounding outer uterine tissue layer. So with the subserosa, they can develop into the pedunculated fibroids, where we have a fibrous with a stalk, and they can be quite large. And the third one is the submucosal. This type can push into the cavity of the uterus, and this is found in the muscle beneath the inner line of the wall. I think with all the types of the fibroids, the one that can cause several miscarriages is what the subword mucosa. They are the number one cause of what? Miscarriage. When it comes to what? Recurrent what? Abortion. The woman with fibroids experiencing recurrent, you go in and you find out, oh, the type of the fibroid is what? Subword mucosa. Because of where they are what? Found. So they can push themselves into what? The cavity. So this is the classification. I'm sure you've seen. We have the fundus subword serosa, submucosa, the intramural, and what? And then we have the peniculated subword mucosa. So we have symptoms. That is around 1 in 3 women with fibroid would experience symptoms. So every 3 women, there's one who experiences what symptoms. We have menorrhagia and anemia for what heavy what period. They experience low back ache or even what leg what pain. Some experience constipation. There's discomfort in the lower abdomen. That is those with what large what fibroid. Frequent urination, dyspareunia, and what others. But fibroid is really what troublesome. Can lead to what labor problems, pregnancy problems, fertility. In fact, fibroid is really what troublesome. So what is the cause? It is what? Unknown. Nobody knows the cause of what? Fibroid. And sometimes we just relate them to sometimes estrogens and what? That's the hormones. We also have what? Genetic what? Factors. It is believed. We have people in your assuming your immediate mother or even a less grandmother, or there are people with what fibroid. The likelihood of you also developing one is what? Very, very what? High. Then consumption of high red meat, alcohol, caffeine, or being overweight or obese. We believe that all these are contributing factors for one developing what? Fibroid. And diagnosing mostly is through what? Ultrasound, MRI, hysteroscopy, laparoscopy, and others. These are ways that we can what? Detect what? Fibroid. We can't detect them with what? Our naked eye. It is what? Impossible. Okay, midwives, how do you manage fibroids at your facility? How do we manage them at our various facilities? Who can share with us before we move on?
Sister, please, this is Vida.
All right.
Okay, so in my facility, where the comes with fibroids, it depends. If it's an advanced stage, the gynecologist will book the woman or the woman in question and do hysterectomy. And then if it's not advanced, then myomectomy is done. Some even come with bleeding, and those ones, if they don't have fertility, like if they don't intend to give birth again, they put them on depot to reduce the bleeding before going in for either myomectomy or hysterectomy. Probably she's not having any child and wants to give birth, then the depot will be withhold. Then the myomectomy will be done for the person. So that's how it's done in my facility.
Facility. Okay. Thank you very much for sharing with us. Yes, any other? How do you handle or treat fibroids at your facility? Who is coming in? We have just a few minutes, so kindly come in and share with us. Yes, Debbie.
Sister,
Yes, Debbie, talk to us.
Madam, sorry.
Yes,
Hello. Good evening, madam.
yes.
Yes, I want to add to what she said that there are some fibroids that are not too big. Like when they
Okay.
have this, the fibroid comes in measurements. And so not all fibroids will have to go through, will have to be surgically removed. Some will be treated with managed with medications and then monitored to see if it will grow. It will grow, like it will keep on growing to the extent that we will need a surgical management or not. So in such cases, if it's not too big, that it cause any, I don't know, discomfort to them, then you keep on monitoring. Maybe let her come for review and then do scan. Schedule her for some scans. I don't know if it will be monthly or depending on whatever rate the doctor recommend, so that you keep on monitoring if it would grow or cause any discomfort. But if it's not growing and causing any serious harm or bleeding discomfort, and then you keep on monitoring. I'm just adding up to fibroids that are not too large and wouldn't cause too much harm to the woman, especially with fibroids that comes with pregnancy as well. You keep on monitoring to check the growth and the size, and then you handle as such. That is what I wanted to add with the little I know.
All right. Okay. Thank you very much. Yes, Olivia, talk to us. Olivia, Queen.
Sister, mine is a contribution.
Okay.
Hello, sister. Hello.
Yeah, we can hear you.
Hello.
Hello, Olivia. We can hear you. Talk to us.
Okay. Okay. Mine is a contribution. The treatment using IUD for treatment for the endometritis. That IUD is different from that of the normal one we use at the family planning, because a colleague of mine was diagnosed with endometritis. Surgery was done on her, and after the surgery, the doctor prescribed that IUD. It's a little expensive. She said around about 2,000.
Okay. Oh, Olivia is off. Olivia was just adding up of the IV used for the treatment for the endometritis. And these are different from the one we use at the family planning one. These are advanced one. Since she has had a personal experience with what her friend. So thank you very much. I think we have some few minutes. So like what you have already shared with us, sometimes with the treatment, it depends on what the size. But the first line of fibroid is what medication. We first give what medication. Sometimes we have the gonadotrophic releasing what hormones and the agonists, and these at least it helps to stop the menstrual cycle. So the first line of managing fibroid is what medication. Sometimes because of the pain, we need to give the NSAIDs, birth controls, and what others. But when the size is big, that is when we think about the hysterectomy and what the myomectomy and what others. And in every surgery also come with its what complication. sometimes when you are there's a hysterectomy, it means what there's no way you can also have what a child again. So definitely it leads to what infertility. Sometimes when you have heavy period, and most of the time their HB is low because what they most of the time experience what heavy but not low. So most of the time their HB is what low. Abdominal pains and pregnancy also what problem. Any questions so far? Because our time is up. Or any addition?
Hello,
Sister, please.
sister.
Yes, by
Hello, sister.
Why we can hear you?
Okay, I wanted to add to the the fibroids. So, in one of
Okay.
our presentations in our facility, one of the gynecologists said that the myomectomy, when they do myomectomy for anyone who comes with fibroids, and the person comes back again with the fibroids again, it's dangerous to actually do a remyomectomy. So unless they do, it's advisable they go in for hysterectomy. When she said a thing, actually some of us didn't really accept it until one of our colleagues recently died out of that. She went to do remyomectomy and then lost her life. So it's something I'm just sharing so that we all take it home. If you do a myomectomy, myomectomy is
Thank you
dangerous.
very much for sharing this with us. We appreciate it. But you know, sometimes it is very
Hello, sister.
oh, the network is not helping.
Hello, sister.
Provider, thank you very much. Yes,
Hello.
Is Betty talking? Okay, Betty.
Please, the one who just spoke, I want to ask her that, did she ask the doctor why myomectomy is not done? Did she ask the doctor? Because from what I know, the myomectomy, it can be done for the second and third time, like cesarean section. So did she ask the doctor why myomectomy is not done? Because I know someone who has undergone two surgery of myomectomy. So did she ask the doctor why?
Yeah, she said it's dangerous. Like I said earlier, she said it's dangerous. Survival rate is it's just dangerous. People can survive, but most of them don't survive it. That's why we lost a colleague recently. So it depends on who will do it, but majority of them don't do it.
Okay, and please, can it be due to maybe the location and the sizes of the fibroids? The location, why the myomectomy is not done? Can it be due to the location or the size of the myomectomy?
Well, that one there I can't tell. It was a presentation we had, and she gave that. She presented on it and said that. So it's not as if it's not done. It's done, but survival rate is low. People go and get survive. Some, yes.
Like all that brother is
Thank you.
even though people are doing it though, but it is not the best. Because sometimes the bleeding is just the blood loss is too much. And this will lead to what? At least mortality. But one thing is when it happens in case when the woman has no child or even just one child, sometimes it's very, very difficult going in for what hysterectomy. So sometimes they just try. You know, medicine is just a try and error. Yeah. sometimes at least we try. It's not all what in the same case that what it can happen to what you go in for the second time, but it is not what advisable. It is not. Those who go in for myomectomy, they really lose a lot of blood. Yes, Edna, your hand is still up.
Hello, sister.
So most of the time, the fibroid keeps on reappearing. At least the woman has 2 or 3. It is best we what cancel her so that at least she can go in for what hysterectomy and be free. Yes, Edna, talk to us.
Yeah, I'm saying that mine is about the uterine malformation. We had an experience. A 13-year-old adolescent came to our facility with severe abdominal pains, and then we took a scan, and then we realized there was an ovarian